Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I'm Chenda Ho, Senior Consultant at Singapore General Hospital and guest editor with CLD. I'm here with Dr. Kevin Tang in internal medicine at the University of Pennsylvania and the author of Direct Oral Anticoagulants in the Treatment of Portal Vein Thrombosis in Patients with Portal Hypertension, publishing later this year in CLD. Dr. Tang, thank you so much for joining us.
Thank you for having me, Dr. Ho.
Well, thank you so much for your contribution. I had a few questions to ask you on your article, so I guess I'll just get started. One question that came to my mind is, what is the efficacy of DOACs compared to other agents for the treatment of PVT?
That's a great question, Dr. Ho. I think traditionally the treatment of PVT had been with agents like vitamin K antagonists like warfarin and low molecular weight heparin. With the newer agents, these direct oral anticoagulants or DOACs, now more common being used, with being more research being studied with its efficacy as well as other things. Actually, DOACs have been found to have similar recanalization rates compared to heparin, and actually greater rates than warfarin in patients with both non-cirrhotic and also cirrhotic portal vein thrombosis. That being said, most of these studies have been observational or retrospective studies and also conducted in patients who have compensating cirrhosis. So there is more studies that need to be done and looking at how these agents can be used in decompensating cirrhosis.
Thanks. How do the adverse events of DOACs compare to other agents for the treatment of PVT?
Another great question. I think when we use anticoagulants, one of the biggest things we worry about is bleeding risks. And DOACs have actually been found to have a similar risk of major bleeding events compared to heparin, actually even less bleeding events compared to warfarin. And I think a big cause of why there are actually less bleeding events compared to warfarin is that warfarin is just a very tricky drug to use in people with cirrhosis, just given that people with cirrhosis have impaired liver synthetic functions, just making INR less accurate in monitoring them. So overall, pretty positive in terms of the adverse events that DOACs have compared to other agents.
Thank you so much. And my last question is asking more about kind of your clinical experience in patients who have been using DOACs. Have they given you any feedback with regard to using DOACs for anticoagulation? Have they had any challenges, or do they actually find that it might be easier than some of the other agents that we've discussed?
Yeah, that's also a great question. I think in terms of patient preference, DOACs actually are preferred in the populations that they can be applied to. Generally, they don't require routine monitoring such as warfarin, so it's much easier to use. Also, there's increased ease of use compared to injectables such as Lovenox. I think the one consideration with DOACs are that they are more expensive than warfarin and Lovenox. So if price is a factor, it may be difficult to kind of get patients use of that DOACs.
Well, thank you. Thank you for your excellent summary, and that was really interesting. Dr. Tang, thank you again for joining us for another installment of the Clinical Liver Disease video series. And thank you everyone for joining us. On behalf of all of us on the CLD team, I hope you found the segment on DOACs for PVT treatment helpful. For more information about portal hypertension and treatment, please visit us at www.cldlearning.com. Thanks again for watching.
Thanks, Dr. Ho.
Thanks.